In this video, I answer questions from a viewer with primary progressive MS, or PPMS. If you want to better understand primary progressive MS, don't turn away, because that starts right now. Howdy! Thanks for learning about MS with me, Aaron Boster. I started this YouTube channel to help my own MS clinic patients learn between visits, and it's my hope that through these videos, I can help you learn too. Today, I'm answering questions posed by a viewer, Sharon Vernia, who has primary progressive MS. Sharon writes, "Hi Dr. Boster. Maybe you can direct me to one of your videos if you've already addressed this before. I have PPMS. I know that it is progressive and that Ocrevus is the only med for me currently. My questions are..." Well, let's hit pause. Sharon, that opening statement included a lot of really important information, so let's start by unpacking what you just said. For starters, let's clarify what we mean when we say progression or progressive. My favorite way of helping people understand the underpinnings of progression is to talk about the leaking pool model of multiple sclerosis. A good friend of mine, Dr. Stephen Krieger, who is a professor at Mount Sinai University in New York, has developed an amazing model to help us conceptually understand multiple sclerosis. The formal name is the topographical model of MS, but I lovingly refer to it as the leaking pool model of MS. I have a few videos on the channel where I talk about the leaking pool model of MS, but by way of review, I thought I would go over it right now. What you see here is a cartoon schematic of a swimming pool. On one end we have the shallow end, on one end we have the deep end, and if you look at the label number 1, this is the water level, or the clinical threshold. Now, the way I like to think about clinical threshold is everything above the water level, the human being is aware, meaning they have a symptom and they know about it. I can't see well out of my left eye, my right foot is numb. These are symptoms that the human being is aware of, and they would appear in the model above the level of the water. Now, below the clinical threshold, below the level of the water, these are things where there's still structural damage caused by MS, but the human being is unaware. It's asymptomatic. And so they're not going to manifest new neurological symptoms, they're not going to manifest an attack, but you can see new spots on the MRI. And so that's what we mean when we refer to number 1 as the clinical threshold. The amount of water in the pool is referred to as the functional neurological reserve, or functional reserve, and that's label number 2. And you notice that there's much less water at the shallow end of the swimming pool as compared to the deep end of the swimming pool. Now, when I say functional reserve, what I mean by that is the nervous system's ability to withstand an insult. Not "you're ugly," but an insult such as not sleeping, or having a febrile infection, or having a major psychosocial stressor, or having a surgery, etc. And one of the ways to think about functional reserve is your ability to skip sleep. When I was younger, 18 let's say, I could literally skip a night of sleep and not really worry about it and just sleep the following day. As I make this video in my mid-40s, just saying that to you makes me exhausted. And so as we age, our functional reserve diminishes. And the reality is in MS, it can diminish much faster. Now, as we talk about functional reserve, I just want to again point out that there's a lower functional reserve in the shallow end as compared to the deep end. Now, the last piece of this pool is described in label number 3, and this is the floor of the pool, which represents the central nervous system. The area that you see coded in pink there in the shallow end are areas of the nervous system that have a low or small functional reserve. So these would be things such as the optic nerves and the spinal cord. Damage to one of those structures doesn't go unnoticed. And in the model, it's represented by a small amount of water, a small functional reserve. Now, in the middle, where you see sort of the middle range in yellow, this is the infratentorium, or the brainstem. The brainstem is more forgiving, if you will. It has a larger functional reserve than the optic nerves and the spinal cord, but it's still not a very large functional reserve. And this would be the functions of the base of the brain. Now, on the far right, where there's the largest amount of water, the deep end of the pool, the green section of the floor, this is the cerebral hemisphere. So these are the lobes of the brain, and they are where we find the largest functional reserve. Now, as we start to understand Stephen's model, the leaking pool of MS, we see that there are these white stalagmites pushing up from the surface of the pool into the pool water. And some of them, like you see in number 1 here, crest the surface of the water, and some of them, like number 2, do not crest the surface of the water. Now, these base effects, Stephen calls them base effects because they're coming up from the base of the pool, really reflect inflammatory activity. I define activity as a new clinical attack or new spots on an MRI. Now, a new clinical attack would be represented by label number 1 because this stalagmite of activity pushes up from the surface of the pool and it crests the water surface. It's above the clinical threshold, and so the human being will experience a problem. Now, we notice here that number 1 occurs in the part of the brain in this model, which are either the optic nerves or the spinal cord. So this would be the equivalent of having an optic neuritis or a transverse myelitis. Now, if you look at number 2, this is also an area of activity, but it didn't crest the surface. The human being would not have experienced a clinical symptom, and yet on the MRI, we would see a new bright spot. And so as we think about an individual with MS, within the construct of this swimming pool, we can start to overlay episodes of inflammatory activity, whether that be an attack or a new spot on the MRI. Now, this video really focuses on progression, and Stephen's pool model does a great job of understanding progression, so follow along with me. Now labeled with label number 1, the clinical threshold. This is the level of the pool water. Remember, I refer to this model as the leaking pool model of multiple sclerosis, because over years, in a very slow fashion, the pool is losing water and it's draining. And so in this cartoon here, you see how the water level has dropped. In Stephen's model, progression comes from areas of previous structural damage, where there was at one time inflammation, and it's damaged the tissue of the brain or the spinal cord. As the clinical threshold lowers, as the water drains from the pool, you uncover these areas of prior structural damage. This is the underpinnings of progression. A clinical example would be someone that suffered a transverse myelitis back in the day, and their legs were numb and they had trouble walking, and they recovered function. Now fast forward 15 years, their legs are slowly starting to get weaker and starting to become more numb. It's occurring very slowly over the order of months, if not years, and it occurred 15 years after an initial attack. The idea here is that that area of damage to the spinal cord didn't fully repair itself. And as the individual ages and as the spinal cord ages, it starts to wear out. And so we see the area of progression as a subsequent event following acute bouts of inflammation. A separate analogy that also might help you understand is the hypothetical where I shoot a bunch of shotgun blasts into a wall and I make holes in the wall. And then we opt for some reason not to repair the wall. Now, the building doesn't fall down, but one of the walls in the room has a bunch of holes in it. If you fast forward 50 years and the house is getting older and the materials are starting to wear out, which wall falls first? Clearly the one that has the holes in it. So Sharon, I hope that helps us understand the concept of progression in multiple sclerosis. Clinically, it typically manifests as a slow worsening in neurological examination independent from attacks. And the way Stephen's model explains it, this is likely to occur in an area where there's been previous activity, either inflammation on the MRI and or from clinical attack. Sharon shares that she has PPMS, or primary progressive MS. And primary progressive MS is an individual with MS that has progression from day 0 and really has had no or almost no clinical attacks. If we look at the most recent diagnostic criteria, we define this disease using clinical and radiographic and CSF information. So I want to kind of walk through that process with you. Number 1, a person has a slow progressive decline in neurological function for at least a period of a year. So that's the first criteria. The next thing that's required is to prove so-called dissemination in space. And that can be accomplished a couple different ways. You can do it by either having one or more classic MS T2 lesion. And so that would be looking for lesions in the periventricular white matter, the cortical or juxtacortical position, or in the infratentorium. So that's one piece. The second one would be to have 2 or more T2 bright cord lesions. And the third option would be to have oligoclonal bands. And you only need to have 2 of those 3 things. So in quick summary, we define PPMS diagnostically as an individual that has a slow, steady decline in neurological function spanning at least a year, with 2 of 3 of the following: the appropriate brain MRI lesions, appropriate spinal cord lesions, or CSF that shows unpaired oligoclonal bands. Now, I have a couple videos on the channel about progression in PPMS, and I have a video dedicated to how we diagnose PPMS. So I'll make sure to throw a link up above so you guys can check out that video if you haven't seen it already. But I want to unpack this a little further. When I say certain findings on the brain MRI or the spinal cord MRI, I wanted to show you what that looks like. So let's check that out. So in this MRI, you see a spinal cord, specifically the cervical spinal cord in your neck. And this person is turned to the side, and we've proverbially cut them in half. And what you can see is the base of the brain, and then you can see the spinal cord extending down. And the normal color is gray. So very clearly, as you look at that spinal cord, there are these white spots. These white spots are areas where there has been activity or inflammation, and they've left a residual puddle of water, which is what we're picking up here. And so going back to the primary progressive diagnostic criteria, to fulfill dissemination in space, you could have 2 or more spots on an MRI like this one. Now in these 2 MRIs, I'm showing you the brain. And again, we see this nice normal gray color, and then we see these white spots. And the picture on the left is an MRI showing you periventricular white matter lesions. The picture on the right is an MRI showing you brainstem or infratentorial lesions. And so hopefully this helps you better understand when we say we're looking for certain MRI characteristics. These are a few examples of said characteristics. Now, before we switch topics away from the diagnosis of MS, I also wanted to clarify a bit what we mean when we say abnormal spinal fluid. So I have a video that talks about spinal fluid, and again, I'll throw a link up here so you can check out that in full detail. But in summary, we do a lumbar puncture. We draw spinal fluid from a needle in the back, and we look at the proteins, and we compare them to those in the bloodstream. And we can kind of match them up. And so what you see here is an example of unpaired oligoclonal bands. Now the way we do the actual test is we compare bands in the spinal fluid of a person against their own blood. And if we see 2 or more of these bands in the spinal fluid not seen in the blood, then that test is considered positive. Okay, we're almost done with the beginning of Sharon's question, but I want to make one more point of clarification, and that's on her comment about Ocrevus. So Ocrevus, also called ocrelizumab, is one of the MS medications, and it's the only MS medication that's FDA approved to be used in PPMS, which is what I think she means when she says that's her only option. Now, one of my more popular videos on this channel is how does Ocrevus work? And so you can check that out with a link that I'll place up above. Ocrevus is a really interesting medicine that targets with laser focus adult B cells and knocks them out of play. And if you'd like to hear my schoolyard brawling analogy to help you understand how that works, make sure to check out that video. All right, we've now clarified what Sharon means when she says primary progressive MS or PPMS. We've reviewed what I mean when I say the word progression using the leaking pool model of multiple sclerosis. And we've talked about the diagnostic criteria to diagnose PPMS. And we've specifically called out what we mean when we talk about abnormal MRI and spinal fluid. We've reviewed, at least very briefly, that Ocrevus is an MS medicine that's approved to treat PPMS. And with that preamble, we can launch into Sharon's questions. So let's do it up. Sharon's first question reads as follows. Number 1, since there is nothing that can be done in terms of a DMT, why do I need to continue with MRIs? Sharon, I understand that thought process. If there's only one option to treat me and I'm already on that option, or I can't take that option, why bother looking? And I really think that there's a fallacy in that logic. Let me share the following with you. When we do MS clinical trials studying people with primary progressive MS and do baseline MRIs at the beginning of the trial, 25% of those patients have enhancement on their scans, meaning they have active current inflammation at the time the scan was obtained. In my clinic, when we see enhancement on a scan, even if it's asymptomatic, we treat it. Now, I have a dedicated video on that topic, and I'll throw a link up above so that you can check that out. But that's an opportunity to intervene. Moreover, it's important that we have a sense of the degree of activity of your disease. People with primary progressive MS typically don't have attacks, so we're not going to have that clinical metric to tell us there's active inflammation. The only other way to clarify that is to take a picture periodically. The world is ever changing, and right now in the pipeline, there's many drugs being studied for PPMS. Identifying that a given individual with PPMS in clinic has ongoing clinical activity sensitizes us that we need to do more. That might lead us to consider off-label options or enrollment in a clinical trial. In short, I think there is value in periodically imaging people with PPMS. The second half of her question reads, and having said that, why just the brain and not the spine? Now, statistically speaking, if a person is going to have asymptomatic lesions, they're more likely to show up in the brain than they are in the spinal cord, and that has to do with the anatomy. Lesions in the spine generally don't go unnoticed. They can, but it's not as common. And so if you're thinking statistically, you're more likely to catch something on the brain than the spine. That being said, and given that PPMS tends to have predominant activity in the spine over the brain, I do think it's reasonable to get both. Now, before moving on to Sharon's second question, I want to remind everyone that there's more to be done than just take a medicine. And I want you to be 4 for 4 in your fight against MS. Being 4 for 4 involves taking an MS medicine and make sure it's working. But there's 3 other things that we need to be doing. Number 2, we want to make sure that you're exercising as part of your lifestyle. Number 3, we want to make sure that you're not smoking cigarettes, which speeds up MS by almost 50%. And number 4, we want to make sure that we're supplementing low levels of vitamin D. Are you 4 for 4 in your fight against MS? If you are, or if you're not, please leave a comment down below. Let me know which ones you're still working on and which ones that you're already doing. Sharon's second question reads as follows. Number 2, is a person diagnosed with PPMS versus relapsing MS by the clinical picture that is presented, or is there something that looks different on the MRI? You mentioned that PPMS usually has more lesions in the spine, but not always. Does this go back to the clinical presentation? Well, as I mentioned a little bit earlier in this video, the way that we make a PPMS diagnosis involves clinical aspects, MRI, and spinal fluid. We're looking for a clinical picture of a slow, insidious decline in neurological function spanning at least a period of a year. Then we're looking for 2 of 3 ancillary tests to buttress the diagnosis. Those include abnormal brain lesions, abnormal spinal cord lesions, and cerebrospinal fluid that's abnormal and showing unpaired oligoclonal bands. And we need 2 of those 3. So the answer to the question is really yes. We're looking for certain features that are clinical and certain features on the MRI, including the spine, as well as spinal fluid. So I hope that helps. Sharon's question number 3. Why is only Ocrevus able to be used for PPMS? Why don't the other drugs help? Does it have to do with the cells that are targeted? And can you explain how? Sharon, to date, we have tried and failed using multiple medications to treat PPMS. There have been failed clinical trials using interferons, using Copaxone, using rituximab and Gilenya, and in secondary progressive MS, Tysabri. And so it's not for lack of trying that we've attempted to explore other drugs to treat PPMS. Thus far, the only drug that has had significant positive results is Ocrevus, and as such, it's the only drug approved by the American FDA and the European EMA for use in PPMS. That doesn't mean that there won't be other drugs, and in fact, there's many drugs in the pipeline being studied for progressive disease states. So this is just where we are current day, 2019. Stay tuned, and it's my sincere belief that we will have more drugs to treat PPMS in the relatively near future. Sharon's fourth question reads as follows. Number 4, why does this tend to show up in an older population? Although I have heard people say that they have had PPMS for 30 years. The average age of onset of relapsing multiple sclerosis is 30 years old. And typically for the first 10 to 15 years, relapsing MS is characterized by periods of clinical quietness, punctuated by clinical attacks or relapses. If you follow the population of relapsing MS out 10 to 15 years, a portion of them have gone on to have so-called secondary progressive MS, where they're developing a slow, steady decline in neurological function, largely independent from attacks. To compare that, in PPMS, the average age of onset is 40 years old. In PPMS, as I discussed earlier, generally is devoid of relapses or clinical attacks, and people have a slow, steady decline in neurologic function. When you compare relapsing MS starting at age 30 with attacks and then developing progression 10 to 15 years later, and compare that to primary progressive MS that starts around age 40, you start to see that maybe they're not so dissimilar. And theoretically, the person with PPMS is having subclinical silent disease, possibly for that entire decade, but it never reaches the clinical threshold, and then they have a slow, steady decline. Many of us believe that in fact it's the same condition that's manifesting phenotypically or the outward expression to be slightly different. That's my personal belief. We have yet to clarify this point, and there's another belief that it's two separate diseases. I just don't think that one's right. Question number 5. You may have lost your crystal ball. Do you think that there will be a cure for MS in my lifetime? I'm 60. My answer is no. I don't think there will be a cure for MS in my lifetime. I don't mean that to sound negative or to be a Debbie Downer, but our understanding of immunology and the underpinnings of MS is ever growing, but we're not there yet. I do think that it's realistic that in my lifetime we'll make MS boring. I don't know that we'll be able to cure the disease, but if we can halt it in its tracks and make sure that you live a full and happy life with a normal life expectancy and a normal life quality, that's a goal that I think we will be able to achieve during the course of my career. Question number 6. Do you think there will be something also to help reverse or repair the damage done? And my answer is, I think there will be. Presently, we have a bunch of medicines to treat relapsing MS and one medicine to treat PPMS. And all of those medicines could be characterized as being anti-inflammatory in nature, intending to decrease bouts of inflammation. In order to beat this disease, it's my opinion that we really need 3 kinds of therapeutics: the anti-inflammatories that we currently have, as well as a remyelinating agent and a neuroprotective agent. And whereas we have not been successful yet in proving that we have agents that can do that, there are many, many being studied currently in the pipeline. And so I do think it is realistic that we will, in the relatively near future, hopefully in the next decade or 2, have remyelinating agents and neuroprotective agents along with our anti-inflammatories. Stay tuned, we're working on it. Question number 7. This is more specifically related to my case, so maybe you can't address it. I have severe small fiber neuropathy in the left leg, which is also my weaker side. Am I able to distinguish if my symptoms belong to one diagnosis over the other, or does it really matter? My mentor, Dr. Omar Khan, used to sometimes say, sometimes nature is a little too generous, and you can have MS and small fiber neuropathy. And you bring up a really good point. To the human being, you don't differentiate the type of pain, it just hurts. And whether it hurts because of spinal cord damage or small fiber neuropathy, you might not be able to sort it out. Now, understanding that you have both is important. And for someone who has primary progressive MS, which may be followed clinically or with spinal cord MRIs, and small fiber neuropathy, which might need to be followed in a different way clinically and with other tests, such as special types of EMGs that do QSART testing, we want to keep a handle on if one is getting worse or both is getting worse. It's also important to look for the underlying causes of the small fiber neuropathy, because some of those are treatable. The point about does it really matter? In some ways it doesn't, because the medicines that we use for neuropathic pain, whether that be small fiber neuropathy or spinal cord damage, are the same medicines. They're typically off-label meds originally invented to treat seizures or depression, and they work to treat both forms of neuropathic pain. Excellent question. To learn more about progression in multiple sclerosis, click that video right there. YouTube thinks that you would love this video right there. If you're impacted by MS and you want to up your game, make sure to subscribe to my channel by clicking that circle right above my head. My name's Aaron Boster, and thank you for learning about MS with me. Until my next video or my next live stream, take care.